Everybody, this lecture will be covering autopsy hearts. I am Alexis Snyder. I am the kind of autopsy pathologist assistant here at Michigan Medicine, and I hope this lecture serves as a good foundation and gives you more confidence in your approach to hearts, as these will be covered often within the autopsy service and something that we really want you to start feeling comfortable with and the gross findings associated with them. So like all grossing, we want to work our way from outside to in. So as soon as we get off that rib cage, we are kind of exposed with two of the main external features of the heart, including the pericardial sac as well as the epicardial surface. So if you shift your attention to the image on the right here, what we're seeing is kind of a more normal heart. So put this in your memory bank for normal. And why I say this is we've got an open pericardial sac. We're looking at the anterior surface of the heart. And we've got nice exposed brown tan muscle, as well as appropriately placed adipose tissue overlying the vessels of the heart here. Now, getting into our more abnormal findings within our external. So we'll begin with the photo to the right. So what we have is an open pericardial sac again, held by this gloved hand. And what we can see is these kind of stringy bands between the pericardial sac and the epicardial surface. These are known as either fibrinous adhesions. They can often be seen after people who have undergone a surgery or if some sort of infectious etiology is occurring within the body. I believe Dr. Gordon likes to call like a bread and butter or butter on toast. If you're toasting bread, it kind of looks like butter being smeared. I'm not so sure about that one, but whatever works for you for remembering this process. Next, we want to look at the heart in the middle here, the bright yellow one. So when I was showing the last heart with kind of exposure of the muscle, here you can just see adipose tissue. So this is definitely an abundance. I wouldn't call this kind of a normal presentation of epicardial surface adipose tissue. I would, in my report, definitely call this increased. And it also is correlated to obesity as well as atherosclerotic cardiovascular disease. So a good indication for what you might find elsewhere in your autopsy as you work through the process. And in the heart to the left here, we have this kind of white patch here on that anterior surface. And this is just a fibrous patch, sometimes known as a soldier's patch. I don't think the etiology is 100%, or not etiology, but pathologic indications. I think it's associated with a rub between the anterior surface and the pericardial surface, kind of creating this patch of fibrosis, but still something you want to document. So other things. So this is working our way back. So on the photo to the left here, this is what it looks like when the body is opened. So we have the cut line of our rib cage, got our sternoclavicular joint here, of course, left lung, right lung, and then the heart in situ within the pericardial sac. And what you'll see here is kind of a really dark discoloration, because the pericardial sac outside of the adipose tissue is traditionally pretty translucent. And so to me, this raises a red flag in the literal sense of that it's likely what we see in these other photos, a hemopericardium. So I like to pause. We have a great photography here at Michigan Medicine. I definitely want to take photos of what it looks in situ. I want to get my measured suction ready as well as measuring cups to record that volume, because it'll present with a little bit of loose blood that we see on top here, as well as clotted blood, both of which you want to record. And then once we see that, we got to figure out, well, what's the source? Before we get into that, again, working our way from outside to in, the first thing that we tackle once the heart is out of the body are the coronary arteries. Okay, to orient ourselves when the heart comes out of the body is really important. So to the left here, we kind of have the front aspect of the heart, and to the right here, we have the back aspect of the heart. So when looking at the front of the heart, we have our aorta, our pulmonary, and then tucked away behind both of these big branches is the left main, which should arise, from an ostia in the aorta and then bifurcating. So the left main then feeds into this left anterior descending artery and our left circumflex artery. Our right coronary artery also has its own ostia, as we know, and kind of hugs around that right atrium and right atrial appendage. And then coming back around, and we'll discuss this later, but since I believe 80% of us will be right dominant, meaning that the right coronary artery is feeding that posterior descending artery. Also looking at the back of the heart, we can see the branches of our left circumflex. So the left circumflex can also continue this way with branches of OM2, and then OM1 should be, of course, before OM2, standing for obtuse marginal. So these three are the main ones we care about and will dissect. So we start at the left main and we serially section at intervals from 0.3 to 0.5. And I'll explain more in depth why this is important. So again, we are doing this on the heart with control because we don't want to cut too deeply into the muscle, but we want to make sure we're cutting all the way that we can see the lumen or occlusion of said lumen within these vessels. So we follow that down all the way to the LAD, the LCX, which again hugs the left atrium and atrial appendage here, and the right coronary artery. We can also switch up the way we dissect things with a blunt dissection. So focusing in a more traditional way, these are bluntly dissected a left anterior descending artery, a bluntly dissected left circumflex artery, and a bluntly dissected right coronary artery. And what I mean by bluntly dissecting, because traditionally you don't want to cut these open, but you're kind of getting underneath the vessel and reflecting it off the heart, and then we put them in decal. So we use these for just very stenotic vessels that you can't really cut through accurately with either a blade or a pair of scissors. And then it can give us nice cut sections, and you can see how marked this atherosclerosis here. So this looks like 90% here. We've got an occluded vessel here, and again, bordering on that 95 to near occlusion in this vessel. So very severe coronary artery disease. In the images on the gray board here, this is kind of a method we apply for bypass grafts. This is something we'll tackle more closely within the autopsy service, but you can see how complex these get. So this is the left main, going into the LCX, going into the LAD. We have a graft that also comes kind of across, feeding probably one of the obtuse marginals, as well as, it's cutting across. As well as we are seeing the LAD bifurcating into one of its branches as well, and just how complex these dissections can get. We want to evaluate, in these cases, both the patency of the graft themselves, as well as the distal portion of the newly supplied native branch or coronary artery that's being assisted by one of these bypass grafts. So again, it gets very complicated, and we'll discuss why you're here in service. So why do we put in all of this effort into these coronary arteries via the blunt dissecting off or serially sectioning? That has to do with atherosclerotic stenosis. Importantly in the medical examiner setting, but can also come across in your hospital autopsy deaths as well, is that atherosclerotic stenosis of 75% or more is associated with sudden cardiac death. So if we have kind of no other acute source, but we have the 75% stenosis, the black part being the lumen, the white part being the atherosclerosis, and how just little we have for the blood flow, you can see why that could be a problem. So this is why we take our time. This is why we section at such small intervals, because we don't need a large span of atherosclerosis, stenosis to associate a sudden cardiac death. We really just need that one focal area, and we certainly don't want to miss that because it can be easily missed if you section too wide in between your cuts. Okay, now that we've discussed coronary arteries, let's get into opening the heart. So again, the process is coronary arteries first, followed by opening the heart. Just to reorient ourselves, because grasping this anatomy will probably be one of the more challenging concepts you'll have on this service of the heart. So beginning again with the front, we have the aorta, the pulmonary, we've got the LAD consistently there, a right atrial appendage, the right coronary artery should be hanging out over there, our left atrial appendage, and then flipping to the back, structures we can see is that left atrium. This IVC also kind of hangs out more in the back of the heart. Again, that posterior descending artery, OM1, OM2. Sinus runs this way. And that's just kind of the front and back aspects that we have here. In adult hearts, this is our standard practice. When we discuss pediatric hearts, I'll reserve that for kind of in the field learning for now. But for adult hearts, we will do these apical to mid sections. This will not be performed in kind of our standard pediatric cases, but this is the method for most adult hospital autopsies or adult autopsies in general. So what we see here is that we have the heart on its front surface. What you want to do is line up your cuts indicated by a blue line, and of course we're using our long trim blade with the fibrous skeleton of the valves of the heart, which you can kind of feel. So this is kind of the plane we want to be parallel with when making these sections. And you, to start out safely, can leave it in 1 centimeter thickness intervals. Certainly you can challenge yourself later, but again, remembering the texture and somebody more decompy, the heart's going to be floppy and not that rigid and will be harder to cut, so just adjust accordingly. And what we're sectioning up to is until we reach these kind of mid to superior papillary muscles here. And what I'll do, just to double check, is that you can always look at the bottom of the heart and see how much further you have to progress until you're probably too far. Okay, so now that we've cut those sections, we can start performing flow of blood. So if we follow the rules of the heart, we know that blood enters into the heart via the vena cava into that right atrium. So the first thing we do is we will open the IVC into the right atrial appendage. You see me probed within the superior vena cava. We don't open that. As discussed later and in the autopsy service, leaving this SVC intact is important for kind of orienting yourselves in regard to dissecting out the SA node, which will kind of hang out within this entrance of the superior vena cava into the right atrium. So we leave that intact. So again, first cut, IVC into the right atrial appendage. What this does is expose our right atrium. Now that we've exposed our right atrium, we can get into what I like to acronym as LAPA, following the flow of blood. So once the right atrium is exposed, following flow of blood, we know the right atrium has to go to the right ventricle. And I like to make this cut either laterally or, if it helps, posterior. Our next cut will be anterior, following the right ventricle, again with flow of blood, into the pulmonary. That pulmonary will then go into the right and left lungs and return to the heart via the left atrium. So then the next cut, when our left atrium is opened, is from the left atrium to the left ventricle, again following flow of blood, approaching from the posterior aspect. And our last cut is back onto that anterior surface. We go from the left ventricle and distribute to the rest of the body via the aorta, our nice oxygenated blood. So why we do it in this order is that this will preserve your heart anatomy. It allows your heart to be kind of put back together if necessary. You're not going to cut through any valves a second time. Of course, we're going to cut through them to get our open circumference measurement, but they can always be appreciated and re-put back together by following this order. So that's why I say you can do basically a PAPA or a LAPA. I just don't want all anterior cuts or all posterior cuts or vice versa, because then your heart will be kind of destroyed and not be able to put back together properly. Okay, so getting into that, remember we opened our IVC into our right atrium, starting at the lateral aspect or the posterior aspect we're looking at. You can see my scissors kind of heading down that lateral posterior part. We're going from the right atrium into the right ventricle. I always recommend, until you get comfortable, probing your cut surface or your cut path until, again, you feel comfortable. So you see my scissors heading from the right atrium into that right ventricle, which will expose our tricuspid valve. Again, you want to measure from your edge to your edge for the circumference of your valve, and also check the patency of your foramen. It should hang out here, because you will come across incidentals in adults that have lived a long time that still have a patent foramen ovale. Okay. Getting into our next cut, again, we are in the A, so we're back onto the anterior surface. We have our right ventricle here. You see my probe, again, right ventricle into the pulmonary. Why I highlight the septum here is that you do not want to cut through the septum. You want to cut essentially parallel with the septum. So anterior, parallel with the septum from the right ventricle into the pulmonary. This exposes our pulmonary valve, which we have cusp system now. And again, from cut to cut, getting our circumference. So again, pulmonary going to the lungs, return back to the lungs into the pulmonary veins. So you have them probed. I would go ahead and open up, again, exposing your left atrium. And then, again, we're looking at the posterior aspect of the heart and going from the left atrium to the left ventricle, following that LAPA, making now that cut, which exposes our mitral valve, or our bicuspid valve. So we have our left atrium. If this was truly patent, this would be the other entrance point of our foramen. And we're measuring again from cut to cut the circumference of our mitral valve. Okay, and now lastly, again, back to that anterior surface. You can see my cut here when we went from the right ventricle to the pulmonary. Now we're going from the left ventricle into the aorta. So again, we're being mindful of that septum. We are going anteriorly and parallel to the septum into the aorta. You're going to have to do a slight curve cut, because you can see the folded over pulmonary valve here, and we don't want to cut into that again. So we're going to cut, make a curve out into the aorta. And this is one probably until you become very, very comfortable. I would always probe your pathway. And what that exposes, of course, is our aortic valve. Again, want to measure the distance, make gross notes. Looks like there's some mild atherosclerotic change or calcific change. And why we do it this way is we have our anterior mitral valve leaflet intact. And we can flop this heart back together if needed, and everything should stay nice and put back togetherable. That was a word. Okay, getting into the important measurements of the heart. Wall thickness and chamber size. So this chamber size might be a new concept to you, but something that we perform here regularly often. So when we take our wall thickness measurements, you can see in black here, we go from, the epicardial wall to the endocardial surface, but not including the trabeculae or the papillary muscles. We kind of pick up that measurement when we are doing our chamber sizes. So we are including the papillary muscles and the trabeculae in this case when we're getting our chamber size. When we do the chamber size of the left, we just need one dimension because classically it should be more circular than the right ventricle, which is a triangle, which is why we do the two measurements here. So this box kind of represents the very loosely associated normal measurements you should expect. So when we get past this 2.5 of the LV, we can start commenting on if things are looking dilated. Same thing with the right side. So carrying that on, when we are doing wall thickness, again, for the septum, I can't see that one too well. For the septum, again, mid-septum, not including the trabeculae or the papillary muscles, so measuring from there to there. And from the right ventricle, I would always, always, always measure from the inferior posterior aspect. So you can see the anterior aspect often gets fatty replaced, and this will be important for sectioning as well, but same concept, not including the trabeculae or the papillary muscles, getting the true wall thickness. We talked about this as we went through it. I would recommend that as you're going with flow of blood, you just measure as you go, but just a reminder that we do want the circumferences of all of the valves as well. Getting into weight. So weight is a very important indicator of cardiac pathology. This is when we start getting into myopathy territory, indicated by the weight that we see with our hearts. So you can, of course, weigh it fresh when you get it, but some other practices include kind of weighing it after you've completed all these steps, because this is a guarantee you have a heart empty of clots. When you're weighing the heart, either way, you want to make sure it's trimmed down. So we don't want a big, long strand of aorta or pulmonary artery. We want to make sure those are trimmed to about 1 centimeter above their takeoffs, so we don't have an excess skewed weight from additional tissues. So again, that concept of weighing after cutting, we're removing postmortem clots, so that adds to the accuracy of the true weight of the heart. Again, use the weight references in the references and resources folder. CAP has established a very nice website, or partnered with the Autopsy book website, where you can kind of plug in the numbers and your BMI for your decedent, and it should give you reference ranges and percentiles to see how significant the weight of your heart is. If you ever go to an area that doesn't have a rule for its own cutoff, or just to raise a red flag in your own head, this paper suggests that once you have a male with a heart over 500 grams and a female with a heart over 400 grams, that should be some sort of alert of this is abnormal. Again, if you don't have access to reference ranges. Okay, now that we've cut open our heart, we've taken our measurements, let's pay close attention to some of our internal findings that we can have. So one of these findings that can be associated with a hypertrophic cardiomyopathy and I believe this photo is from a case that had one, is this atroflac fibrosis. So you can see how like red and glistening kind of the distal parts or the mid-apical heart is, and then we get this like hazy gray white fibrosis right in the left ventricular outflow tract. This is associated with a rub of the, again, myocardial valve leaflet rubbing against the surface in, hypertrophic hearts. But I also have seen it in more of incidental hypertension. But you have a large heart with this fibrosis, you can take an extra section to try to look for that myocardial disarray, which we will talk about later. And are infarcts. So I like this heart picture because it shows kind of the range of infarcts someone with atherosclerotic cardiovascular disease can have. So along this left lateral wall, we have more of a gray, tan, either like old or infarct versus has it gotten to become a full scar yet kind of area. This is actually the heart that we saw with that hemopericardium or the tamponade case, in which we see a full thickness rupture due to an infarct. So something that's more recent is going to be hemorrhagic. We've got some tan discoloration as well. Just to note that if you have an occluded artery case but you don't see an infarct, that also contributes to the thought of sudden cardiac death, meaning the body hasn't had the time to kind of build a cellular response to these changes. So often you might not see anything within the myocardium in those types of cases as well, just to note. Okay, dilated. So why are we doing those chamber sizes? So this is definitely more easily appreciated when you have the heart in person, but I've tried to include this little slide from this photo, which is about 2.5 centimeters, which is kind of the normal point of how big your chamber size should be for the left ventricle. And I can fit about 2 of those plus. You can really appreciate that this has a chamber size on the left of about 5 centimeters, which is essentially double what you would expect from more of a normal heart. So this is what we are getting into with dilated hearts and enlarged hearts. I am really surprised I couldn't find a better photo for this. But in contrast to that last slide, you can see how kind of obscured the left ventricle chamber size is. Yes, we do have some massive papillary muscles, but we do have a pretty thick wall, a very thick septum, as well as a thickened right ventricular wall. So we're getting more of an enlarged, bordering on hypertrophic or cardiomegaly territory. Amyloid. So amyloid can be a tricky one, especially with these senile cases. So on the left here, it is a bit of a hazy photo, but you can see kind of this weird coloration and septal thickening, which also to know is something you can see in hypertrophic cardiomyopathy. So just as a note that, not all of these are exclusive, and why you need to use your medical knowledge to kind of differentiate between the two. So in this amyloid heart, again, this has to be a good textural feeling because the myocardium itself will feel much firmer, right? It's getting amyloid deposition, kind of changing the texture and the structure of the heart. But yeah, compared to a nice normal brown, you're getting a yellow, tanny, pinky kind of discoloration. But that's not always exclusive. This patient was much younger. This was a case of senile amyloidosis and kind of looks pretty normal. But on every microscopic section, there was diffuse amyloid everywhere. So just to be aware of kind of the different presentations that this disease process can have. Okay, a cooler case we have is this is sarcoid. So in certain sarcoidases, it almost looks like an infarct, but you don't have that usual extension from one surface. It's almost like lodged between our epo and endocardium. And again, very clearly, kind of looks like an infarct, but in this case, it was a young patient with sarcoidosis with also lesions found in the lung. So we've seen all of these gross abnormalities. What sections do we take? So I wanted to just bring this back because you'll probably hear me throughout this entire lecture flip between inferior and posterior. And why I'm saying that is we just have to remember how the heart sits within the body, why something is called the inferior vena cava, even though when the heart's nice and flat, it looks like it's from the posterior aspect, and so on and so forth. So the anterior surface stays pretty consistent. The inferior surface, kind of rests along this diaphragm and is what you'll see when you have your apex to mid cuts, where truly posterior kind of hangs out near the atrial area or the base of the heart. Why this is important is that you'll hear Dr. Morris often referred to ALICE, the acronym. Before we get into that, we'll just get into standard heart sections. So all those boxes highlighted in green are our standard heart sections. We take one from the left ventricle. Again, I prefer the posterior of how it looks to you, but truly it's inferior aspect. And we want to see the cut surface we're looking at currently. So often you're going to have to block these out and then thin out a section again. And we want to see epicardium to endocardium. Same thing for our septum here. We take it always within the middle. The closer we get to these transition zones, you'll more likely incidentally pick up some naturally occurring what looks like myocardial disarray because we have two different patterns of muscle kind of converging together. So we don't want to set off a false alarm. So I take a nice one in the middle here. And lastly, our right ventricle, always, 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 again, taking it from that anterior aspect because of how fatty replaced the anterior aspect gets. So you can take a longer section of this because you'll want to thin it out lengthwise. Because again, we want to see epi to endo. So if you are suspicious of some sort of cardiomyopathy, this is when you want to apply these blue boxes, and this ties into ALICE, is what Dr. Morris will kind of call this acronym on her cardiology consults, and that stands for LV, here I'll change this to blue, LV anterior for our A, LV lateral for our L, LV inferior for our I, septum for our intraventricular septum, and then we always submit right ventricle as well. It just doesn't fit cutely into the acronym here. Again, going back to additional sections, if you had a heavy heart with this area of fibrosis, go ahead and take a section through it as if it was another septal section as well. Okay, that's all I have for you. This lecture was adapted from a presentation I gave for my professional organization, so apologies for all the slogans, but if you need me, these are my emails. Again, you'll become very familiar with our morgue photographer, Lisa Neal. All these images are courtesy of her skill, as well as the guidance of Dr. Morris for our beautiful heart standards that we have here. Thanks.